So guess what? It's your fault. Let's continue with the discussions. It'll be more clinical. In my opinion, it'll be more pleasant as well, but that's up to you to decide. There are a relatively small family of autoimmune diseases or failure of self-tolerance or self-recognition, and systemic lupus erythematosus, usually just abbreviated as lupus, even though there's another kind of lupus. But when you hear somebody say lupus, they're talking about systemic lupus, is always at the top of the list because it's basically your body not tolerating your own DNA. How do you like that? In rheumatoid arthritis, it's systemic. Even though it's called arthritis, it's not limited to the joints. It's not localized. It's systemic, but it's still called rheumatoid arthritis because that's where the primary expression is. It's also vasculitis and other things as well, skin. Another systemic autoimmune disease that is really systemic, even though it may primarily affect salivary glands, is called Sjogren's syndrome. There's another misleading term called scleroderma, which is now more properly called systemic sclerosis or progressive systemic sclerosis, which is not just limited to the skin, although the skin may be a primary area of clinical expression. And then we have a variety, another type of these called a mixed connective tissue disease, which is also systemic because connective tissue is everywhere. And then many of the vasculitides, there are maybe many vasculitises within these diseases, but there is a primary vasculitity called peri or poly arteritis nodosa. It doesn't matter what you call it. Peri and poly are both appropriate terms, in which you can say the problem is not in a localized area like a thyroid or a testis or a neuromuscular junction or a parietal cell. The primary problem is everywhere. But remember, even in some of the localized diseases, after you study them further, you can find other areas of the body. And that's why some of these systemic ones were at first made it look like it's localized. But these localized classical autoimmune diseases are a type of thyroiditis in which you make antibodies against your own thyroid. In one case, the antibodies against your thyroid causes your thyroid to slow down or be impaired. In another case, antibodies against your thyroid result in the thyroid being overactive because the antibodies activate your TSH receptors. Or you could have antibodies against your own red blood cells or antibodies against the protein in your white matter of the central nervous system, antibodies against your testicular tissue, antibodies against your kidney and lung basement membranes, antibodies against your platelets, antibodies against the cells which make intrinsic factor, which are also the same cells that make your stomach acid, antibodies against your own beta cells in insulin-dependent or primary or diabetes type 1, antibodies against your own neuromuscular junctions. They're relatively localized. So I want you to remember a couple things, is that this list of localized autoimmune diseases grows by leaps and bounds. And you could probably almost theorize that if you have a chronic inflammatory disease and it is not being caused by an external infectious pathogen or microbe, then there's a good chance it will ultimately be called or classified as autoimmune, because most autoimmune diseases result in inflammatory reactions which are loaded with lymphocytes and macrophages, or a chronic inflammatory pattern. Talk about the big one, lupus. It's a disease. Well, every disease has to have these four things. It has to have an etiology or cause. It has to have a progression of cellular events. It has to have a clinical expression. And it has to have morphology, either clinical or radiologic or anatomic. So it's very easy. What's the cause of lupus? antibodies against your own DNA, or the protein that supports the DNA, the histones, or your nucleolus, which is RNA, or your non-histone RNA as well. It's a progressive disease resulting in all the things we talked about: antibodies, deposition, coating of cells, and basically it's a disease against all of the cells in your body that have nuclei. How do you like that? So the symptoms are many, 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 many things. But when they first attack a critical organ like a kidney, then that's often considered, the primary or most feared clinical expression. Morphology could be, depositions in your glomeruli. It could be in your skin. It could be a certain type of skin rash in the face, which they call a butterfly rash because it's symmetrical and it looks like a butterfly. And maybe I got a picture of that somewhere too. Here's a butterfly. Here's a lady with a butterfly on her cheeks or malar aspect. They call it a bimalar symmetrical rash or a butterfly rash. And I'll do you a favor by showing it to you as a little movie because butterflies like to flap their wings. I've been on 80 different hikes this summer, and I've always tried to take a picture of a butterfly that was standing still, and I still haven't been able to do it. But here's the classical lupus butterfly rash. Here are fluorescent antibodies labeled against nuclei of cells. In this case, it looks like the antibodies coat the nuclei uniformly. So this is called the homogeneous pattern. In this case, it coats the antibodies at the rim of the nucleus more than anywhere else. In this case, it's speckled. It is not homogeneous, it's not at the rim, but the antibodies just kind of form clumps everywhere. And finally, we could have antibodies against the nucleolus as well, which of course is primarily RNA. So these different patterns, for example, like the homogeneous pattern, the speckled pattern, the rim pattern, they may determine not only different features of lupus, but different features of other autoimmune diseases as well. Like scleroderma is usually speckled, okay, and polymyositis, it's often nucleolar. But the most specific antibody for lupus is the anti-double-stranded DNA, okay? And by the way, if I made a mistake, if somebody knows it's the single-stranded, please give me the right answer. Is it single or double? I think it's double-stranded, but I may be telling you something wrong right now. I'll have to look it up next time. Here's some deposition of antigen antibody and therefore cellular infiltrates in the dermal epidermal junction. That could be causing a lot of the skin rashes. If you coat the antibodies against this material with a fluorescent compound, you may see a fluorescent line, or here you have antibodies against your glomerular basement membrane of your kidney. So they look like the glomerulus is just loaded with antibodies against its own basement membrane. Here is some depositions within a glomerular capillary as well. And the part of the glomerular capillary that forms the basement membrane. Okay, remember that's one of the three magnets. We said synovium, we said glomerular basement membrane, we said skin, and we also said synovium. So, you can have a synovitis and arthritis in it as well, and you can still call it lupus rather than rheumatoid. How do you like that to make it complex? Here's some cardiac valves, and it can form a reaction on the surfaces of your cardiac valves as well, a little thickening or what they call vegetations. And the thing about lupus is that it's the only common disease that causes vegetations on both sides of the leaflet of the cardiac valve. Most of the other diseases form vegetations just on one side. These are called Liebman sacs. They're classically diagnostic for lupus, even though it may be a postmortem diagnosis. Now look, because lupus affects every nucleated cell in the body, just about everything you could imagine could have a problem. Blood cells, synovium, skin. But when you get to the kidney, which is usually present 50% of the time, even though it's only present 50% of the time, in the skin or hematologic, maybe almost 100% of the time, this is when we start to get severe renal problems. So the classical feature or the classical presentation of a lupus would be a woman, because all of these autoimmune diseases are more common in women, would be a woman that comes in relatively young with perhaps renal problems or renal failure. That's a classical clinical patient presentation, or what I call CCPP. Some of the more other systemic autoimmune diseases, rheumatoid arthritis, even though it's arthritis, is systemic. Sjogren, even though it's salivary glands, it's systemic. Scleroderma, even though it's derma or skin, it's systemic. You have the connective tissue of the lungs and the GI tract and everything. Periarteritis nodosa, also called polyarteritis, because it often starts on the outside or the peri or the adventitial aspect, but it's poly, meaning multiple arteries. And nodosa, it means that the part of the artery that is involved may be thickened or nodular. So this is like a perfectly good name for that systemic autoimmune disease, even though it may be expressed primarily in the arteries. Now look, even though you have an arthritis here and a salivary gland problem here and a skin or lung or problem here, these type depositions may also be present in lupus as well, or vice versa. Here's a rheumatoid arthritis. You know, normally synovium has 2 layers of cells. The one layer is a fibroblast kind of a cell which secretes the synovial fluid, and then underneath that, the second layer are macrophage-like cells. But what if this nice little double layer becomes infiltrated with all these inflammatory cells? Why? Because it's a war going on here. It may be attacking. So a rheumatoid arthritis starts out as a rheumatoid synovitis. With time, it may destroy the cartilage, the bone. Can also common to have vasculitides in this, and it also may form little fibrous nodules throughout the lungs and skin and everywhere else. Here's Sjogren's. Just to remember that even though you may say, well, look at all these lymphocytic infiltrates in that salivary gland, although you don't know that's a salivary gland yet, neither do I, resulting in the parotid gland becoming inflamed. This could be part of a systemic syndrome. And the reason why it's called sicca, that means dry, this is keratoconjunctivitis sicca, not just the salivary glands, but the lacrimal glands, conjunctivitis. It's going to result in this woman perhaps having a dry mouth and not being able to make tears either. Okay? This is a normal salivary gland. Look, you got ducts, you have acini, you have granules. This may be a mixed salivary gland because I see some mucus areas rather than serous areas as a mixed. But look at this salivary gland, like we saw here in the picture. You can barely see these little ducts and acini anymore. There's just massive infiltrates of lymphocytes and macrophages as well, a destructive process. Here's progressive systemic sclerosis. Used to be called scleroderma. That was the worst name in the world for it, because even though it may have presented as fibrosis in the skin, especially the skin of the digits, forming these little contractures, basically it occurs wherever you have connective tissue, you know, like esophagus, like lung. And it's one of the common types of lung diseases that will result in a restrictive kind of a lung disease. This is scleroderma. You may still hear the term from old-fashioned literature and old-fashioned doctors. but it's called systemic sclerosis, or even more better, PSS, progressive systemic sclerosis. Here's skin. And if you remember, you have kind of a looser papillary dermis near the papilla of the epidermis, and then you have a little bit denser, deeper dermis. But look at, in scleroderma, you had just dense fibrosis all the way through. But imagine this being in the esophagus, or the lung, or the liver, anywhere where there's connective tissue. The classical local autoimmune diseases, the two most common types of thyroid disease resulting in either hypothyroidism or hyperthyroidism are both autoimmune diseases. In the hypo one, you're making antibodies against your thyroglobulin and your microsomes, and you can see a whole bunch of inflammatory lymphocytic infiltrates in the thyroid. And in Graves' disease, you're making antibodies against your TSH receptors. And you're thinking, well, wait a minute. If you're making antibodies against your TSH receptor, shouldn't that result in a hypothyroidism? No, because the TSH receptors are then activated. In multiple sclerosis, you're making it against your own part of your white matter, your myelin basic protein. If you had something called an autoimmune arthritis, you could imagine that this person, this man, is making antibodies against his own testicular tissue. In Goodpasture syndrome, you're making antibodies against your glomerular basement membrane, type 4 collagen, remember, 4 on the floor, as well as the basement membrane in your lungs as well. So a Goodpasture syndrome might present as a guy with hemoptysis who's also in renal failure. The most common cause for thrombocytopenia in kids or adults, even though there's two different, it's a similar process. You're making antibodies against your platelets and therefore fixing complement and destroying them and making them reduce the number to the point where you actually may have spontaneous bleeding. In pernicious anemia or type of megaloblastic anemia, you're making antibodies against your intrinsic factor, which enables your vitamin B12 to be absorbed further down in the GI tract and your ileum. In your anti-parietal cell antibodies as well, which means you may have decreased stomach acid. If you make antibodies against your own beta cells, you're going to be diabetic. If you may have antibodies against your neuromuscular junctions, you may have nerve muscular problems, frequently presenting as eye muscular problems in relatively young women. So these are the classical synopses of the common classical, and some of them even original, localized autoimmune diseases. Okay, we're down to one of our near to our last topic. What if you have an immune deficiency syndrome, or IDS? Well, if it's primary or genetic, you're born with it. That could be called a primary or PIDS, or probably even better yet, I think I would rather use the word GIDS because it's genetic. But if it's not genetic and it's acquired, then you could call it AIDS, because now it's secondary. You're not born with it. These are the definition of the family of the immunodeficiency syndromes. Now, in the primary ones, the genetic ones, I am not going to blow your mind and give you the clinical presentations of all these diseases because you won't remember them, and I'll probably need about 6 hours of extra time. But what I will tell you, that in the primary genetic immunodeficiency problems, you have problems in enzymes which enable your lymphocytes to differentiate. And depending on where that differentiation problem is in the tree between the developing T cells and the developing B cells will determine your particular type of primary inherited genetic autoimmune deficiency. And in Bruton, you have no antibodies. In IgA, you have just a problem with IgA. In hyper IgM, you have too much IgM, and maybe you have a deficiency of something else. In a more severe things, you may have a common variable, okay? If you are looking at the T cell portion of the lymphocyte developmental tree, because you may have thymic hypoplasia called DiGeorge syndrome, or another severe combined immunodeficiency. And why is it called severe? Because the enzyme defect occurs in the early development of the T cell differentiation tree. If you have a primary thing with thrombocytopenia and eczema, that's classical presentation for the other type of primary disease called Wiskott-Aldrich. Or think about it. If you have problems in the enzymes which make your complement components, that you may also have severe problem with lysing the offending cells. So I'm not going to go into the presentation, but let's just say if a baby is born and they have much more than their share of neonatal and childhood and infant infections, then you can probably work them up for one of these genetic autoimmune primary immunodeficiency diseases. Here's the lymphocyte tree. I think this is the best way of all to understand it. Let's say that you know that the early lymphocytes, the pro-lymphocytes, will then develop into cells, which could then differentiate into the B cell line or the T cell line. And the higher up you go with a deficiency of an enzyme that would help differentiate the lymphocytes, the more severe the deficiency is going to be. So if you have a problem here, you don't have any antibodies. But if you have a problem here or here, maybe you only have a deficiency of A or something else. Same thing with the T cell end of the lymphocyte differentiation tree. A defect in an enzyme like ADA, which is adenosine deaminase, that occurs in the early stages of T cell might result in both types of T cells. The CD4s and the CD8s is not working. That's worse than having only one. So this is the general scheme for all of the primary immunodeficiency genetic diseases. And I didn't have to spend 6 more hours going through each one. Now, you might want to know in general, if you have primarily a T cell defect, what are the kinds of problems you're going to have? Or if you have a primary B cell defect, what are the general kinds of problems you have? Or if you have a defect in your granulocytes, what type of a defect might be present? Or if you have a defect in your complement, what are the common infections you'd expect that baby to get? Well, in the T cell defects, the primary problems will be viral diseases, okay? In a B cell defect, you're going to have antibody problems, and your primary problems are going to be in your your pyogenic bacterial diseases, like staph, strep, H. flu. In your granulocyte defect, you would probably expect a Pseudomonas and staph as being the big bugs. And in a complement defect, for some reason, the Neisseria infections, like pneumonias, for example, and meningitis, might be a problem, and other pyogenic infections, very similar to the B cell defects. So that's one way of generally looking at it, but think about it. A T cell defect, you can have problems with bacteria or viruses. The same thing with the B cell, but these are the primary areas of concern if the defects are in your T cells, B cells, granulocytes, or complement. I think I probably got this chart from Robbins, and it's one of the few things I blatantly plagiarized, and it's one of the best charts I've ever seen. So what about the acquired immunodeficiency diseases, of which we'll talk about this being a secondary process because you're not born with it, you acquire it by virtue of being exposed as an etiology to the HIV virus. And pardon my redundancy because the V stands for virus already. The pathogenesis is exposure of this virus to various cells, particularly lymphocytes, but many other cells have been indicted. Then you have a clinical reaction, an acute reaction, a lymph node reaction, a latency period, which may last for many years, 7, 8, 10, 20 years even. And then finally, the ultimate destruction and disappearance of your T cells, which opens the door then to many not only regular infections, but infections of what we call opportunistic infections, infections by bugs, which people don't normally get infected with not only the disappearance of your T cells, but the rapid rise in your HIV viral load as a full-blown AIDS expression. So, epidemiology, we all know where you get it. We all fear that we don't get it. Still about half are homosexual, but that's been declining, pretty rapidly. The intravenous drug exposure has been about the same, and the heterosexual incidence of epidemiology has been significantly rising, just like the homosexual has been decreasing. Well, here's the etiology. It's a virus. It has little protein receptors called GP120, or their stalks, the GP4. It has a coat. It has a lipid layer. It has a capsid. It has a genome of only approximately 15,000 nucleotides, believe it or not. But in that, we have about 9 genes, which are not only coding for the anatomic structure, but for the 2 or 3 actually, significant enzymes that enable it to do its invasiveness. Here's the pathogenesis. Viruses are exposed to the surfaces of cells. And I know you would like to think they're lymphocytes, but I've been to so many AIDS conferences where they show HIV inside of brain cells and inside of epithelial cells, but we can think of them as primarily a T lymphocyte virus if you want to. With time and the membrane, now we have the reverse transcriptase causing and the protease causing the appearance of new viruses, which first start as little buds on the lymphocytes and then into a mature. So here's a early budding stage. Here is a late budding stage where there's still a little stalk. And of course, here's a bunch of new viruses as well. Mature new virions. So what causes that? Well, we'll talk about the most 2 important enzymes, which are part of that 9-gene genome. And of course, the first one that was studied and the first one that was the therapy was directed against was reverse transcriptase. Well, it's a very easy concept to understand. If in transcription you convert DNA to RNA or messenger RNA, that's called transcription. But remember, the virus is a retrovirus. It is not a DNA virus. It's an RNA virus. So it has to convert into DNA in order to do its job, to successfully integrate with the host cell chromosomes. So that's reverse transcriptase. And many of the therapies were directed against it, and they had generally not that much of a success, maybe a little bit. And of course, there's another enzyme now called protease, also coded in one of these genes, whether you want to call them GAG or PAL or VIF or VP, or these are only 9 genes. Can you imagine that? We have millions of genes, but the viruses have 9. We have 4 billion nucleotides? The most viral genomes are only about 15,000, and in this case, you have only 9 genes, but enough to make all the structural and enzymatic things. And the second most important enzyme was protease, because that's how it incorporates, that's how it eats up the proteins of the host cell. And of course, with the addition of protease inhibitors, we have now significantly increased the longevity of the patients with AIDS. And I don't want to sound too optimistic, or I don't want to be slammed, but I think most of the people that treat AIDS now can tell you that it's almost at the stage where it could be a chronically manageable disease. It's not that they don't have a normal lifespan, but the addition of the protease inhibitors has made a marvelous difference. The clinical pathogenesis is, first of all, the exposure of the viruses to the cells, make it a dendritic cell or a lymphocyte, and you have a primary infection. This then develops into a lymphoid infection in the lymph nodes, and about, maybe a few weeks, I would say a few weeks, you have an acute syndrome. And very, very often, I've talked to some experts on AIDS, and they say very often you don't really have much of an acute syndrome as well. You might think you just might have a little cold or a little shivering for a couple hours or something, but that's the acute syndrome. There's an overall immune response and a latency period, and during that latency period, there's a silent, progressive destruction of T lymphocytes. And as the T lymphocytes are destroyed, if you go below a certain count, you could then diagnose full-blown AIDS rather than just AIDS positive, or as the production of viruses, as measured by the viral load, the RNA viral load, progresses after a long, perhaps 5, 6, 10-year latency period, you now can have something called full-blown AIDS, which opens the door to both regular infections as well as opportunistic or rare infections. And I want to make a point right now, because I had always thought that pneumocystis carinii lung infection was one of the most common infections in AIDS. And it certainly is almost unheard of without an immunodeficiency state. But somebody very, very rightfully pointed out to me, he goes, no, it's regular pneumococcus, Don't think that just because you have AIDS, you're going to get only opportunistic infections. You still get many, many, many regular or non-opportunistic infections. It's only the appearance of the opportunistic ones which make you know that there is a severe immune deficiency. I won't bug you with this chart, but I will say, there's an initial rise in certain antibodies, which of course is the thing that makes you HIV positive. The antibodies which are on the surface of against the surface appear earlier than the antibodies against the interior, just like you have with many other viral diseases like hepatitis. And then, of course, in the years after this long latent period, not only do the viral particles or viral load start to rapidly rise, but you now have a progressive destruction of your T cells as well. So this is the one part of the chart you should know. In the appearance of the full-blown AIDS, you are starting to shoot up on your viral load and rapidly destroy your lymphocytes and other cells, So lymphopenia, of course, is an immune abnormality. So you have decreased T cell function, both the 4s and the 8s. And even though your T cells are the primary targets more than the B cells, there is classically B cell activation. Perhaps it's a way of making up for the decreased T cells. I don't understand it, but it's called polyclonal. So you might have destruction of T cells, but an increase in all types of antibodies. And remember, once again, you can also have decreased monocytes or /macrophage, because monocytes are the same as macrophages. It only depends on whether they're in the blood vessel or in the tissue. And I bet you can't think of a single cell in your body that has not been reported at one time or another of being infected by HIV. But those are the primary ones, the T cells. So infections are all infections. But if you took a list of the so-called classical opportunistic infections, things you would never see in normal people like Cryptosporidium, Pneumocystis carinii pneumonia, now it's called Pneumocystis jirovecii. So I still like to call it PCP, and most people do, rather than PJP pneumonia. Toxoplasmosis, something we're all exposed to, normally don't get. AIDS patients can get it easily. Just like we're all exposed to Cryptosporidium, it might have been in some of the water you drank from the faucet today, but you'll never get an infection with it. Well, the AIDS patients can. Fungal diseases in general, not just the superficial ones or the skin ones, but the deep ones like histoplasmosis, blastomycosis, coccidiomycosis. You get those much, much more often in AIDS patients than you would ever get in a non-immunocompromised patient. Fungal disease, infections in general are regarded as representing some type of immune defect. TB, the number one bacteria, Salmonella, Nocardia. Just when we thought TB was on the run, we got this epidemic called AIDS, and TB is the primary granulomatous mycobacterial infection of HIV patients, as well as our regular family of herpes virus, CMV, which of course can infect anything, HSV, varicella zoster, and HPV. And remember, some of these viruses, like HPV and especially HPV, can cause cancers as well. So do you think that AIDS patients have a much higher increase of squamous type carcinomas caused or largely contributed to by HPV? The answer is absolutely yes. Let's see if I got a nice picture here of an x-ray. And the radiologist, without much imagination, you could look at this x-ray and say, yeah, you have infiltrates, but they look cottony. So the radiologist might call this a cotton wool or a cottony or a fluffy type of infiltrate. It's kind of funny that that word cotton is used, because when this is biopsied and the pathologist looks at it, he sees these little cottony critters inside of the alveoli as well. And they may look all nice and pink and homogeneous, but if you do a stain specifically for the Pneumocystis carinii or Pneumocystis jirovecii organism, you may see that they're nice and black. And why are they black? Because even though it's a protozoan, it has many features with a fungus. And if you remember, the fungi stain black on this silver stain. But if you've seen a million biopsies like I have, when you start to see an exudate like this, you know pretty much that you're going to have those little black PCP critters in them when you do the iron stain. Cryptosporidium. Okay, this is a protozoan also, and it operates chiefly on the epithelial cells, okay, of the intestines. And you could see it extensively involved them as an infection, diarrheal illness. But in a non-HIV person, you can be exposed to a Cryptosporidium, which we all are, believe me, and never get a diarrheal infection. In AIDS patients, it's something important to worry about. Same thing with toxoplasmosis. You know, cats harbor toxoplasmosis, and if you have a cat, you're not going to get it, but AIDS patients do not keep cats for pets. Here's a type of infection that's characterized by a classical granuloma, with the chief cell being macrophages. You want to call it type 4 hypersensitivity. Also, some of these macrophages fuse nuclei into the cytoplasm, causing giant cells. There's often a little cuff of lymphocytes. And then as this thing might get older and older over months or years, you can have fibroblasts eventually causing a scar in which it's probably not even infectious anymore. But a caseating granuloma is regarded as tuberculosis until proven otherwise. And it's one of the big things that AIDS patients get because of their problem with T cells rather than non-AIDS patients. Many of the AIDS patients, particularly for some reason, AIDS patients that had homosexual contact, get this low-grade vascular malignancy called Kaposi sarcoma. And, these are red skin blotches. And they normally, even though it's a sarcoma, and sarcoma means malignancy, they normally do not metastasize, but sometimes they do, and I've personally seen more than a few. Even though the cells that are basically destroyed are T cells in AIDS, we told you that the antibodies, or B cells, actually proliferate. And wherever you have a proliferation of cells, you make that more likely to become involved in a lymphoma process. That doesn't mean that hyperplasia in itself is premalignant, but malignancy occurs with cells that are normally turning over faster. So B-cell lymphomas are characteristic of AIDS patients, even though most lymphomas are B-cell lymphomas. Almost all of them in AIDS patients are B-cell lymphomas. A lymphoma of the brain is virtually unheard of before the AIDS epidemic. Now it's the most common brain tumor in an AIDS patient. Okay, and because HPV proliferates because of the lack of T cell regulation, the HPV will also result in a much increased incidence of squamous cell carcinoma in the cervix or other squamous non-keratinized epithelial areas where HPV proliferates. Well, we're down to the last couple of slides, and I really want to thank you for putting up with me because there's been a lot of material, but it'll be completely within 2 hours. I promise not to keep you. Another type of immune sort of a disease is a very common disease, which everybody has, by the way, but sometimes it really gets out of control. This is called amyloidosis. Amyloidosis is basically a buildup of, let's find the first one here, of immune protein. So most of the amyloid protein is a result of buildup of amyloid light chains, ultimately from antibodies. But you can have other types of amyloid which are not builds up of immunoglobulin proteins. And then you can have another type of amyloid that builds up with Alzheimer's disease. Okay, now it builds up at first in the blood vessel wall. So in early amyloidosis, you might see amyloid protein either by staining or by electron microscopy involving the walls of blood vessels, making them thicker, similar to atherosclerosis. But with time, a whole organ, like a kidney or a liver or a spleen or heart, can just be loaded with amyloid, not just tiny blood vessels. So that's the nature of the disease. And I want to tell you that this buildup can cause interference with functions of tissues and organs. The way to detect it is to do a special stain called Congo red. And I know what you're thinking. You're thinking, well, if it's a Congo red stain, it's going to look red, like you see here in the wall of the blood vessel. Yeah, that's right. But if you polarize this with your microscope, this Congo red will now be green. So that is the diagnostic feature, because not everything that causes a red bump in a blood vessel or is going to be green when you polarize it, but if it's amyloid, it will. Most of the amyloid proteins will show apple green or granny apple green birefringence with polarized light. And why would you build up immune protein? Well, maybe you have a myeloma in which you're basically in an uncontrolled malignant fashion pouring out all types of antibody proteins. In the chronic granulomatous diseases, like TB at the top of the list, but all the other ones, you can have buildup of amyloid protein as well. There's an amyloid type of things, proliferation that hemodialysis patients get. That's mysterious to me. Maybe one of you can look it up and figure it out. There's also a type of familial or inherited type of amyloidosis. And the hereditofamilial amyloidoses are usually localized to single organs like liver or heart, but they don't have to be. And in certain tumors, particularly tumors of the thyroid gland, the light cells or the interfollicular cells, which produce not only tumors of these cells, but an excess of calcitonin or thyrocalcitonin. These tumors, which are called calcitonin tumors, which you can often see in multiple endocrine adenomas, especially the type 2 MEAs. You can see them. But last of all least, everybody has amyloid. I'm 72 years old. You're probably around 25 or 30, let's say. I guarantee you I have about twice or three times as much amyloid in my body. And if somebody biopsied a lot of little arteries or blood vessels like they frequently do, even from the abdominal fat pad, they're going to find a lot more in me. And these normally, don't interfere with problems. But now I notice more and more in the literature you're starting to see vascular diseases caused by amyloidosis. Okay, I told you we'd be out in within 5 minutes, and I'm keeping